So for those who may not know you yet, can you tell me a little bit about your background in orthopedics and I guess how you got interested in both longevity and regenerative medicine?
Okay, so I'm a trauma orthopedic consultant. My main interest is trauma, major trauma. So we see really big injured people, and the thing that kills you in serious injury is inflammation. It's huge inflammation that your body can't deal with. So we actually studied that, looked at it, and the institute I work in, I'm a lecturer at the University of Birmingham, is the Institute of Inflammation and Aging, and trauma research sits inside there, but also the aging side. And what we found is that patients who were severely injured, they biologically age, and that aging stays with them. So they sometimes get 8 years, 10 years of biological aging. Biological aging is a slightly controversial word, but it sort of means that, you can measure DNA age, and there are lots of different ways of doing that. But we actually measured it and found that they were older, and that stays with them unless you can do something about reversing it. And so then we looked at things of, so part of reducing inflammation in that patient, but also inflammation in joints, inflammation in the patient as a whole down at a cell level. I got into stem cells about 10 years ago, again, to provide an option to patients other than surgery, especially if they're too young, or athletes or sports injuries for recovery. All those areas, there's been a lot of work abroad around stem cells and showing that it improves recovery. So I got into that space as well. And actually, they're linked really well because stem cell optimization is about harnessing biology. And if the patient's suboptimal and their biology is suboptimal, you've got to do something to try and increase the gains of the treatment. And we actually discovered that if you reduce systemic inflammation in the patient, optimize their biology, their mitochondrial dysfunction, they actually get better responses to stem cells. The stem cells, if we take them from the patient, are also healthier and more vital. So again, all the research in that space was super interesting. And that's how I sort of, I suppose, accidentally became a sort of stem cell whisperer. So we learned how to harvest optimal stem cells, but then also optimize the biology of the patient who we're going to put them back into. And that meant at sort of cell level, we were trying to optimize both the patient and the cell. And in the last few years, everyone's sort of started to call that longevity medicine, because things like lifestyle interventions, people always know about, if you eat healthy, if you exercise. Yes, there are lots of nuance to all of that, because you can actually over-exercise and you can overeat well. So there's a balance to everything. So, and what's really key about that now is with genomic testing and biomarkers and microbiome analysis, the amount of testing you can do on a human actually shows you that what they need is individual. So you need a precision, sort of personalized plan to the person in front of you. You can't just say, well, eat kiwis, for instance, because they're good for everybody. That we've actually found patients that kiwis are not good for.
Wow. Okay.
Interestingly. So, this, and that's how precise this now gets. You can sort of say to someone, you can eat strawberries, but you probably shouldn't. And that level of knowledge now, or at least a guide towards the genome and the epigenetic expression in patients, is so unique for each individual. It's now giving us that level of insight. From fruit to fruit.
Yeah. Insane. Okay. Was there a moment in your career that you felt that conventional pathways weren't enough for long-term patient outcomes?
Absolutely. That's why I became a stem cell doctor to some extent. So in my pathway, I was not trained on stem cells at all. There is no training in regenerative medicine in the UK. So when I first got interested, I thought I need an answer for patients who surgery is not the right thing for. We need to preserve their joints because they're 20 years old or 19 years old and their joints are smashed to pieces. We've reconstructed them, but they then get into problems with early arthritis or dysfunction or scarring or wounds that won't heal. And I thought, we just need an alternative solution. And that's when I explored. I went to America, Brazil, parts of Europe, Italy, Spain, and I learned what other people were doing, which was harnessing growth factors from the patient, optimizing them, putting them back in, getting wounds, chronic wounds to heal that sometimes patients had for 2 or 3 years, reducing pain, managing inflammation in those joints, and actually managed to delay the point surgery was required. And that was super interesting because nobody was doing that in the UK. So yeah, I had to go down a very different route to my training to learn all of this. And for a while, you know, it's quite difficult because in the UK system, there is only one training provider. Everyone's trained in the same box. So as soon as you step out of that box, it's a bit of an unsafe place because everyone thinks, what are you doing? You know, nobody does that. But you realize, one thing I realized is because I had to go abroad to learn all these skills, you realize how diverse medicine is. And in some parts of the world, there are lots of different areas of medicine being explored and validated with good research. And sometimes I found myself in those conferences and meetings sitting there thinking, you know, where have I been? You know, I've been through medical school. I've done 10 to 15 years of postgraduate training, and I have never heard of this thing they're talking about ever. So now 20 years of experience as a medic. Yeah. And I was sitting there for the first time thinking, you know, I was having to Google the name of things that I was listening to in conferences thinking, how come I don't know this? You know, and that was a strange experience to me. I thought, you know, we sort of get trained, you know, there's a degree of arrogance in our training system that we're at the forefront, we know what we're doing. And you realize there's actually sometimes an awful lot of knowledge out there. Yeah. It was not trained by us in the NHS or through conventional medical schools. It doesn't sit inside conventional medical textbooks. And that doesn't mean it doesn't work. So yeah, I found some really interesting research as I've traveled the world now. And I still teach and travel around the world now. And I see some really interesting things. And yes, some of it is quite far-fetched occasionally. And I think the adage does apply that if somebody promises something that sounds like it's a miracle cure, you should be really careful because there are no miracles really in medical care. But there are lots of other plausible things happening with good data behind them, which we actually shouldn't ignore, but we actually tend to. We're broadly blinkered in the UK healthcare market and we just ignore it because it doesn't fit in our orthodox box.
Yeah, makes complete sense, I think. What was the craziest? Where do you feel like, which country you learned the most information from, out of interest?
That's an interesting question because I actually think I learned the most, at least in open-mindedness, from Brazil. Interestingly. And that's really down to one institute. There's one sort of really cool professor there, and he's very cool. But he set up this whole institute with a university top cover for research. He's got a research clinic. He's then got a private clinic. And within that environment, he's got a lab with PhD researchers sitting in the lab. And they are publishing 10, 20 papers a year. And so any idea he comes up with, he tests it. And he's got a research clinic with all the embedded research capabilities in it, with a lab attached to it, so they can actually measure everything as well. And then, you know, a whole team that measures outcomes and publishes the outcome. So they're innovating almost on the hoof. Like, oh, that's a good idea. We're going to change this a little bit. Oh, that's another good idea. Let's change that a little bit. And they'll just treat 20, 30, 40 patients with something they know is safe because they've used it and all they're doing is tweaking it. Yeah. So they're sort of the kings of regenerative tweakments. Yeah. And they tweak something, but they actually analyze it properly. They've got the capabilities to actually analyze it, look at the research, look at the patient outcome, and then go, we've learned something important. And so that I enjoy going there because almost every time I go there, I learn something new. Yeah. You know, I've been to some meetings in Europe where I've sat there for 3 days and not learned a single thing almost. Okay.
So how do you explain longevity and regenerative medicine to patients in simple terms?
Well, I think in simple terms, regenerative medicine is a slight misnomer. It actually, the first thing I say to patients is, what do you think the cells are going to do to you? What do you think, you know, you've come to this clinic, it may be a stem cell clinic. What do you think it's going to do? And usually you find that their expectation is, oh, well, my joint's going to get regrown and I'm going to have the joint I had 20 years ago. And most of them don't think that, actually, to be fair. They've got now the power of the internet and chat, GPT and AI, so they sort of have a decent understanding often when they arrive. But there are a lot of patients still coming out, well, you're going to recover my joint, so I don't need an operation. And the first thing you say is, like, that car's crashed. And it crashed a long time ago. We're not going to rebuild that car. What we're talking about here is symptom management. We're going to give you months or years without pain or less pain. You're still going to probably need that operation, but it's going to be hopefully in 1 to 5 years, 10 years time rather than now. Yeah. And so it's just managing expectation is the key. And I say regenerative medicine is actually harnessing your biology using growth factors and cells, often from you. They can come from other sources as well. And we use those cells and tissue to improve your biology, your structure. And that's what regenerative medicine is. We're harnessing your own biology or optimizing it. And that's why it feeds nicely into what we call now longevity medicine, because longevity medicine is the sort of optimizing your health span. Again, I believe longevity medicine is a bit of a misnomer, because people then see longevity, that means I live longer. I mean, who cares if you live longer if the last 20 years of your life is miserable because you're in pain, decline, dementia, Alzheimer's? So for me, this is optimizing your life expectancy. So your health span is where this is about. If you can live 80 fantastic years and then have 6 or 12 months bad at the end of life, or get to 120 and be running around in the garden till you're 110 and then start to decline, that's where you want to be. You don't want to be, I want to live to 120, but from 80 to 120 for 40 years. I'm struggling to walk and my brain doesn't work very well and I'm in pain. And that's not really quality of life. So for me, it's optimizing quality of life, optimizing the health span to make you as healthy for as long as possible. And the way you achieve that is ultimately about measuring where somebody is and then seeing what you can do to dial them into a better place. So you measure, after you've measured, you make a plan, and then you show a pathway to improvement, and then you remeasure. And what we're doing now is we're seeing patients' biomarkers, their cardiac risk scores going down, their inflammation going down. Systemic inflammation, the biggest killer in the world is inflammation.
Wow.
Most disease, if you think about it, one of the biggest diseases in the world that kills people is sepsis. And sepsis kills you because the toxins that are released by those bugs create an inflammatory response in you, and you shut down, your body shuts down, and you get collapse. But aside from that, if you think, heart disease is inflammation.
Yeah.
Alzheimer's and dementia is that inflammation. It's cancer is an inflammatory process, and metabolic syndrome, of disordered inflammation. So when your body gets exposed to inflammation, it doesn't know what to do with, it can't deal with, something happens. It becomes a disease process. And most diseases are linked to inflammation. Inflammation is the mother of disease. I often quote.
Which conditions or patient profiles benefit the most from a regenerative approach?
So regenerative approach, there's the people who would benefit the most are the ones we rarely see, unfortunately. So people with early arthritis, early changes are the ones who you would be able to benefit the most. They're the ones who get the best outcomes. They're the ones who sometimes you can even delay or stop the disease in its tracks and prolong the lifespan of that particular joint or area of their body for a long time. What we actually get in reality is people who arrive when they've had something for 10 years or 15 years, and then eventually they get seen by a specialist who says, oh, you need an operation now. They've had a 10, 15-year lead up to that, or a 20-year lead up to that problem where they needed the operation. If we caught them 5 or 10 years earlier, or in that first 5 or 10 years, they may not be in that position that they need the operation now. We could have delayed that potentially. Sometimes they may never need the surgery if you catch them very early. Whereas the opposite to that is that the real group that I see the biggest benefit is, because their biology is really good, is young, fit athletes. So if you're a professional athlete and you get an injury, you want to recover optimally, especially if you're a professional, you're doing your job. We see what the differences are between coming first or second.
Yeah.
In competitions, it can be fractions of a second. And if you drop your performance by 1 or 2%, that can mean the difference between being on a podium and not being on a podium, or winning a fight and losing a fight.
Yeah.
So at the elite level, 1 or 2% gains make a difference. And we've seen that we can recover people. Sometimes our pro athletes who the traditional pathway of recovery would be 3 months, 6 months. We've halved that. They're back in training in 50% of the time that they would have been in the traditional way of us treating them. So we can improve the structure of tissue. We can make it heal a little bit quicker. But on top of that, by saving them a few weeks, it means they get back into training, they can get their performance back. But on top of that, the tissue they actually form when you use cells or growth factors is actually of a better quality. So that 1 or 2% gain, instead of getting scar tissue for 50% of that tissue, they get less scar tissue, they get more normal tissue. So that does potentially give them the gain of 1 or 2%, which makes a big difference to them when you're a pro athlete. And that feeds nicely again into longevity medicine, because longevity, again, who comes to us? Mostly middle-aged people or slightly older people, because they're starting to meet disease. They're starting to meet problems. It's like, I feel this and I've got a pain here, and actually my heart's playing up a bit, or my hormones have gone, or something's happened to them.
Yeah.
And the people we don't see are people like you in their 20s, 30s, actually, whereas, again, it's about preventative health, right?
Absolutely.
If you go and meet disease when you're 50 or 60, it's a bigger challenge now for us to sort of optimize your health. Yeah, we usually can get there, because a lot of these 56-year-olds that especially come to us for longevity services are really fit and they're dialed into their health.
Yeah.
But if I caught that person 20 or 30 years earlier, you could have potentially stopped them getting to that point.
Yeah.
They've had now 20, 30 years where they've been eating the wrong foods and their genetics haven't been checked, the biomarkers. But you have to remember, a lot of these tests were not available 20, 30 years ago.
Yeah.
So one thing I think is missing is probably catching that early audience. We should probably starting, at least the screening, at least the measuring, we should be doing in people in their 20s and 30s.
Yeah.
Even their teens, why not?
Yeah.
Saying to them, actually, you're not suited for this kind of food. You're not, suited for this kind of exercise, etc.
Yeah.
That information you can give people when they're super young, which then gives them insights that changes the way they train, changes the way they eat, which impacts them for the rest of their life.
Yeah.
If you give them that information super early, you can change the trajectory of their health in the long term, because they're going to generate less inflammation, less problems for themselves over time. And that should in turn improve their health and their longevity.
Yeah. Okay. Then we need to something for me then. I just realized now, okay, yeah, maybe I should start to myself. Because honestly, at this point, it's like, I want to just do business forever. So I'm just thinking, like, how do I?
But what I'm saying is that the cheaper, and when you're young and fit, you don't need interventions, right? That's the problem. You got to go to short.
Yeah.
But most people don't need interventions. They don't think about it. But it's now where you want the information. So the cheaper packages, the cheap, where somebody just checks everything for you and then says, this is your bank, this is your genome, this is your microbiome, this is all optimized. This is stuff you could actually improve.
Yeah.
This is stuff you can or cannot change, or this is a risk for you, particularly because of your genetics and your profile and your epigenetic profile. And then you can actually do something about that, because you're probably not going to get a disease from that for 20 or 30 years.
Yes. Yeah.
But if you know now, then you can sort of think, well, actually, I'm not going to do what my grandfather and my father did.
Yeah. I understand.
And, people have this idea that I'm diabetic, but my mom and dad were diabetic. My grandfather died because I was going to get diabetes.
Yeah.
Diabetes is not your genetic destiny. What is your destiny is to follow the footsteps of your parents and your grandparents and their behaviors usually.
Yeah.
That's the issue. If you behave completely differently, your genetics can express a different code.
Yeah.
Even though you share the same genes, the genes have the ability to go left or right. When they make it, in simple terms, they can decide left or right. And that decision is made by your behavior, not by your genetic destiny. So if you live completely differently to your parents, your grandparents, you won't share their diseases. And we think that's 80-90% of the load is in your behavior.
Really?
Genetic destiny is probably only linked to about 10, maybe 20% of diseases.
Wow. Okay. So if somebody was like in their 20s and 30s, like what do they need to do? Like what are the steps?
It's just come into clinic. It's a quick screen, because if you haven't got a problem, as in you haven't got a pain or a disease to deal with, then actually all you're doing is, as I said, it's that first step, which is measure. So we just do a mouth swab or a saliva test, take your DNA, send it off to the labs, do a full genetic and epigenetic profile, do a blood test, check all your biomarkers, and we check the ones, these are not biomarkers you get from your GP if you go and see them. Yeah. Those are just standard organ tests. They fall in what we call a normal range. That normal population range includes people with disease and non-disease. So it's a broad range. The GPs in conventional medicine does not teach us what we call optimal ranges. And in certain markers, we've got optimal ranges.
Got it.
And so what we actually do is we look at where your biomarkers are and where they could be and where they should be for optimal health.
Yeah.
We can tell you where you're deficient. We look at your nutrients, toxicity, So we analyze a whole lot of things, 300-400 biomarkers.
Yeah.
And bloods that, way beyond conventional blood tests for just checking if your kidney, liver, and heart are okay.
Cool.
And then we provide risk scores, and we can do biological aging scores, genetic DNA age scores. And we can actually map out, the rate you're aging at. You may be 28, but actually your biological age may be 32.
Yeah.
Because of your behaviors up to now, etc. Sleep being super important, that kind of thing. We're not very good at.
Yeah, my sleep is terrible.
So just being measured first.
Okay.
So DNA, epigenetics, microbiome, which is a poo sample.
Yeah.
Poo sample, detailed biomarker analysis alongside that. And, and again, we check all your hormone levels. Yeah, so it's a really comprehensive test. The clinic I work in, I've built the most comprehensive profile available currently. And you can stack on top of that. There are even more experimental tests you can do. Yeah. But I think the profile we'll build will screen 98% of what we know, 98, 99%. So whether you want to pay thousands of pounds more for that extra 1 or 2% of information, where we don't even fully understand what to do about it, I always say to patients, it's up to you. I mean, some people, they don't mind paying. There is one blood test that I heard recently people are having done in one of the clinics I work in. That's $20,000. Because the test is $4,000 or $5,000, but to ship it in ice rapidly to a lab in 6 hours, which is abroad, somebody charge, the couriers charge $10,000+ for that.
Wow.
So people are paying for these tests, and what the way I equate that to is like, you can go fishing with a rod and be super accurate and catch one fish. The way most people fish, because that's not very efficient. If you want to get lots of information or how many fish are in the sea, you trawl with a big net, and this particular test is just a big net. It's the one that goes right to the bottom and dredges everything out from the ocean. And the problem with that is that you get this huge net with loads of fish in, and you're probably interested in 20% of them.
Yeah.
And the other 80%, you may not even know what they are, and you're not going to eat them, and so, and that's the same with this test. It pulls up 11,000 markers, for instance. We probably only know what a fraction of them do.
Yeah.
So we're sort of dredging for information, and some people want that dredge. So they're paying for it, right? They're like, well, I want to know everything. I want to know everything about myself. And then, so of those 11,000 markers, we probably have an idea of what half of them do. So we can give them some information. We can actually say, well, actually, these proteins are being expressed slightly more than that one, and that's not a good sign. Or actually, this one's higher than it should have been, giving you all, say, kidney disease. So actually, that's a good sign. So you can provide some reassurance, and you can get some risk scores from these proteins. But the other half of that sieve is for research purposes. We don't know what they mean at the moment. Over time, we will.
Yeah. Okay. So interesting.
You can actually measure sleep markers, genetics, epigenetics, and blood biomarkers. And so you can actually see why some people don't sleep as well, or what gain you'd get from sleeping. Biologically where your deficits are. And some people are genetically built differently, so they just only a minority, that's like 1 in 1,000, they actually just need less sleep. They don't need sleep. Others, if your biomarkers come out that you actually need sleep, then obviously it's about adjusting your sleep hygiene.
Yeah, because for me at the moment, the past few months has been like, I've been sleeping 4 to 5 hours for like multiple days, and then one day I'll sleep for like 12. I don't know. That's not good hygiene.
It's not good hygiene, because actually one of the you can manage it, and there is a degree of recovery. So when you're young, you can get away with that. So there is something called sleep stacking or sleep banking.
Yeah.
Which you can do. So there is a recovery period that you can actually catch up on. We used to actually say, if you just go back 5 years, people said you can't sleep bank. If you lost it, you lost it. You're never going to get back.
Really?
But there is some research now showing that if you do a recovery day,
genuinely,
if you do a recovery day, it does actually help. But actually regularity, so because this comes down to circadian rhythms, so actually regularity is as important as anything else. So if you sleep 6 hours instead of 8, your body needs 8, but you're sleeping 6 or 5 or 6. But you're doing it at the same time or waking up at the same time every day. Consistency,
then it's good.
Keeps your circadian rhythm in check, which optimizes your biology and the way your biology responds and your hormones respond.
Yeah.
And so actually you generate less inflammation and less stress on your system and less oxidative stress in your cells. So you can compensate for less sleep by actually having like a few consistent patterns, and those kind of behaviors matter. And from a mortality perspective, consistency is as important as the amount of sleep you get.
I agree, because I think even my uncle, who was actually an orthopedic surgeon in Southern Caulfield, like he's so old now, and like he just sleeps same time, wakes up same time, and like he's super healthy. He's like 70 something, and like fair enough, makes sense. But yeah, at the moment it's been really bad. You can ask me how like I've just been sleeping like 4 or 5 hours, and then like 7-8 days, and then one random day I'll sleep for like 12-14 hours, and then I'll like hibernate for a day, and then like and then repeat the cycle again. It's good funny. Okay, nice. When is surgery still the right option, and when should regenerative approaches be considered first?
That actually simply comes down to patient expectation. So if a patient comes to me with grade 3, 4, like advanced arthritis, especially bone-on-bone arthritis, whichever joint it might be, although depending on which joint it is, does matter. Because, so if the patient expects coming to me that they're going to avoid surgery altogether and they've got end-stage joint disease, the first thing I say to them is you don't want to avoid surgery. What you're doing here is delaying or managing symptoms for a short period. It may even be as little as 6 months or 12 months we can improve your symptoms for. And you're going to need repeat treatments to try and keep your symptoms at bay. And that doesn't mean zero. What we call a good result, we can achieve good results in end-stage joints in about 2/3 of cases. And what I mean by good results is with 50% reduction in pain, at least. So if they get more than 50% improvement, we call that a good result. If they get 25 to 50%, we call that a moderate result. And if they get less than 25% improvement in symptoms, we call that a poor result. So that's how we measure it, for our sort of research and internal clinic processes. The patients who come to me saying, well, I want something that's going to regenerate my joint, and I'm never going to need surgery. That's not a realistic expectation. Anyone with an unrealistic expectation, I just say to them, if you want a long-term permanent result, then it's surgery. You should just go and have your operation done. If you're looking for, even if you've got end-stage disease, but you have a realistic aim where you say, I'm really busy this year, I've got lots of things going on, my daughter's getting married or whatever else. I've had patients come to me saying, my husband had cancer. I cannot have 3 months off.
Yeah.
Worrying about myself while I'm looking after him. So I just need you to buy me time. And that's a realistic aim.
Yeah.
They will give me this year. Right, we can give you a year. We can give you a year where you're more functional, you're in less pain. And we can achieve that in quite a lot of the patients. I said 2/3 plus. And that's a realistic aim. We can help them. Whereas, the patients that the earlier they come to us, the better the effect is, the more reliable the result is. We can achieve 80-90% improvements in people with early arthritis, 80 to 90% of the time as well. So much more reliable, and it can last longer. Our average length of effect in people with stage 1, 2, 3 arthritis, for instance, is around 18 to 24 months. Whereas once you bundle in the grade 4s, the more advanced arthritics, our average length of effect is under 12 months. So that's sort of, those are the conversations. To me, it's about patient expectation. If they have completely unrealistic expectations for regenerative medicine, they shouldn't be having it. And surgery may well be the right thing for them, or they just want, a hip replacement is a very reliable operation. It's one of the most reliable operations that we do. 90+% of patients are very happy and satisfied with it. It gives good long-term results, usually over 20 years of pain relief. And so I often see patients who will come to me and say, look at my hip, and I look at the x-ray and I think, why have you not had a hip replacement? And they say, and if they say to me, well, can you not save it with stem cells? I'm like, no. Yeah. So if you're here to save your hip joint, go and have your hip replacement done, please. Yeah. That's the best thing for you. But there is occasional patients who are too sick, who've been told they can't have an operation.
Got it.
We've got lots of comorbidities and they've got no other options. And they're like, I just need some pain relief. And then we discuss all options. It's not always regenerative. You can do pain blocks. You can actually dial off nerves, do radiofrequency modulation of nerves, etc., that supply joints. So you can turn the nerves off as well in burnt out joints. So that actually can give them 6 months, sometimes even 12 months of pain relief.
Got it.
So there isn't it's not all regenerative. I mean, when you've got all the modalities, combine that with advanced pain techniques and injections into joints, we get the best of both worlds, and we can actually keep people who aren't suitable for surgery going.
Yeah.
With less pain.
Yeah. Okay. That makes sense. That's interesting decision-making process. What excites you the most about the future of regenerative medicine?
What excites me most, I think, is the future of regenerative medicine, because I think it's going to be a key player in the future, the way we deal with patients' illnesses, injuries, recovery, arthritis. I think the future space here is that you pick up disease early and you either turn it off. That's one thing you can potentially do. So rather than waiting for a disease to happen, you can actually turn it off. And sometimes if you catch things early enough, you can do that with regenerative medicine. The other real future of this space, I think, is that when you're talking about cells only, we're talking about, regenerative medicine encompasses things like tissue engineering as well, coupled with cells. So you can imagine the future where you can grow livers and hearts and kidneys. So you actually get rid of the need for transplant, or having donors. You don't need donors anymore because you can grow it in a lab. And that's part of regenerative medicine as well. But that's combining that with tissue engineering. But from a cell point of view, which is where we are now, what I'd really like to see, and it's starting to come, is knowing there's lots of different types of stem cells and they all have different potentials. How to get the most potential cells for a particular problem for a particular patient. Once you can actually match that you have this problem, say with your spinal disc, and your genetics and so on show this, which means you're going to respond. We'll be able to predict who responds and doesn't respond. Because at the moment, we don't know who's going to get a good result and who's going to get a bad result from the same treatment with the same problem.
Yeah.
So we're able to predict that. We'll be able to say, you're a 60% responder, you're a 99% responder. So, people can then choose wisely and go, well, I'm a 99%, I want that injection. And we'll actually be able to engineer injections specifically for that problem with the most potent cells for that particular problem. So we'll have cells available to us, for instance, are engineered to make disc in the spine. That's the real exciting future of this space. At the moment, we are on the edges and periphery of those discoveries, but we're not quite there. And what we're currently doing is mass market treating people with what we think is the best treatment for a particular problem with the most potent cells we have now. But those cells, we often use the same cell in 20 different conditions because we don't yet have that level of knowledge to be able to do that really precise dialing in and go, I need this cell to do this in that person. We don't have that capability, but I think that will become.
Yeah.
And AI will probably accelerate that. And the way that we're engineering cells and we're learning more and we're being able to engineer and test cells better and better and better, we're not too far away from it, I think.
Great. Amazing. I'm also new to the podcasting situation, so I'm going to do something like thanks for your time. You can plug your stuff, basically, where to follow you, that kind of shit. I'll say some sentence now. Okay, awesome, cool. So, sounds like an exciting future. I'm excited to see what happens in the field. But I guess, where can people find you if they want to find out more about regenerative medicine?
Okay, well, I work out of the UK and Dubai. So Dubai, I'm at Zoe Me in Jumeirah, 27th Street. And that's a sort of cutting-edge longevity clinic, a longevity center that also does stem cells and regenerative medicine, some really cool stuff. And it has a complete ecosystem around that. And that's Zoe Me spelled a little bit unusually because it's a Greek name, but it's Zoime. In the UK, it's at Kaizen Clinics. So again, another quite cool name, Kyzn. It means perpetual improvement. And that's where it's from the Japanese philosophy. And that's in London and the Midlands in the UK.
Yes, and then any socials that they can follow you on as well.
My personal is just at Dr. Ansar Mahmood, or it's Kaizen Clinic, or Zoe Me Longevity.
Okay, amazing. Well, thanks for your time. Hopefully the audience gains something from this and in the future of regenerative medicine. So, excited to see what happens next.
Absolutely.